Good afternoon, everyone. Hopefully everyone is able to join us and can hear me fine. Please feel free throughout the program to share comments in the chat and questions you may have. If you have any difficulties, please also include that. So I'm very, very excited to welcome you to the NPF Dermatology Rheumatology Collaborative Program with a focus on pediatrics this afternoon and evening. So I'd like to start off by just, again, offering my warmest welcome and to provide some introductions first about the NPF and then about our speakers in our program this evening. I'm Dr. Stacy Bell, and I'm fortunate to serve as Chief Scientific and Medical Officer for the National Psoriasis Foundation. I will tell you from the start that this program has been in the works for quite some time. We've always had a focus and an emphasis on caring for our young population in the psoriatic disease community. And with wonderful partners like Dr. Kelly Cadoro, we've really done quite a bit behind the scenes and to offer for our patients. But this is one of the first times we're really going to be bringing dermatologists and rheumatologists together to offer this very special educational offering. I'd like to thank our sponsors for the program today. Again, this program is provided by the National Psoriasis Foundation. It is done entirely with our staff and our professional volunteers. With that being said, we cannot do programs without some support. So the program is either sponsored or supported by educational grants by AbbVie, Bristol Myers Squibb, Janssen, and Pfizer. This program is accredited. The NPF is an accrediting organization through the Accreditation for Continuing Medical Education, ACCME, will provide education credit for physicians, both MDs and DOs. With that being said, this credit can also be used for other specialties, and so you will receive a certificate of participation at the end, and that is something that you can provide to your accrediting organization. The NPF is also happy to help with that as needed. Our disclosures for this evening, I'll be introducing each of the faculty shortly, but if you have any questions regarding that, they're listed here. I also wanted to touch on a couple of very important things for the NPF at this point. I think because of everything that we have going on and how we support our community, I want to make sure that everyone that is attending the program tonight is aware of some of these fantastic opportunities that are ongoing right now. The first slide actually depicts a summary for our grants and fellowships program. I'm excited to say that our cycle for our funding for this year just recently opened on October 15th. Applications for these grants will be due on January 21st of 2022. These are a mix of our traditional granting mechanisms and also research fellowships and summer student awards. We have a variety of these mechanisms, many of which can be applicable to pediatric research. And I think many of our speakers today will comment on how they themselves have received funding through this granting mechanism, but they've had colleagues that have. It's a fantastic opportunity to really forward your research, both from a basic science standpoint, translational standpoint, and clinical research. If you have any questions, you can reach out to me as well. We also have another medical program, our mentoring program, that I'd like to highlight this evening. We're constantly accepting applications for this program. It is a very unique program in that it provides diverse mentoring opportunities. So it could be a dermatologist working with a rheumatologist in a peer-to-peer setting. It could be a medical student, a fellow, a resident wanting to learn more specifically about psoriatic disease. It may be a nurse practitioner that is in a general practice and would like to learn more about dermatology or rheumatology. It may be a nurse practitioner or physician assistant that's in a general office and wants to learn more about pediatric psoriatic disease. So with this, we have an application on our website. It's denoted on the slide, and I can, again, provide more information if there's interest in this program. The National Psoriasis also offers a number of benefits through our professional membership program. Programs like today are free of charge and provide credit based on the sponsorship that I mentioned, but also our generous donors. So to become a member of the NPF, again, we have applications on our website. There are a number of educational opportunities, access to patient data. There's also the ability to promote clinical studies or become involved in research, both external to the NPF and internal to the NPF. And then one of the biggest things that I think will offer benefit, particularly for treating your pediatric patient population and educating their parents as well, are our patient education materials or literature that we can offer to our professional members. So with that being said, I'd like to briefly touch on the agenda, and I am also very grateful to be able to introduce our faculty this evening. I'd really like to start by recognizing the team that planned this inaugural Pediatric Dermatology Rheumatology Collaborative event. As I mentioned, Dr. Kelly Cadoro has really led the efforts for pediatric interest at the NPF as of late. She and I have had multiple discussions about having a program such as this, and it really has been a long time in the making. Unfortunately, a global pandemic delayed the effort, but we're now back on track with that. I'd also like to thank Dr. Ekemini Ogbu and Dr. Erica Lawson, who is one of our faculty members this evening. They have really been instrumental as far as planning the content and really thinking about the vision and what we really could offer this evening that would be the most beneficial to your care for our pediatric patients. I'd like to thank our NPF team members, Sue Hayden and Shiva Mozafarian, who have coordinated the event, have really worked with our faculty members to make sure that the event could be, all that it can be this evening. And then, of course, I'd like to invite I'd like to thank our invited faculty this evening, Dr. Amy Poller and Dr. Matt Stahl. Dr. Poller has been involved with the NPF for years. She has been a wonderful partner and supporter for me since I've been here. Dr. Stahl and also Dr. Lawson are really new to partnering with the NPF, and I cannot express to them how much we appreciate that. Most importantly, I'd like to acknowledge all of the children and teens and parents of those youth that live with psoriatic disease every single day. Their stories and how they share with us help us learn from them, help us partner with them for better care, and really are the reason that we're all here tonight. So with that being said, I've done the welcome and introductions. I will briefly turn it over to Dr. Amy Poller. Dr. Poller is the Walter J. Hamlin Professor and Chair of Dermatology and a Professor of Pediatrics at Northwestern University. She is a pediatric dermatologist at the Ann and Robert Lurie Children's Hospital in Chicago as well. And as I mentioned, she has been an avid supporter of pediatric dermatology organizations and patient advocacy for a long time, both with the NPF and a number of other organizations. She's an absolute joy to work with and just a ball of energy. After Dr. Poller completes her segment, we'll turn it over to Dr. Erica Lawson. Dr. Lawson is an associate professor of pediatrics. She's the program director of Pediatric Rheumatology Fellowship Program, and she is at UCSF Children's Hospital. When she completes, we'll turn it over to Dr. Kelly Cadoro. She'll be talking about some of the approaches to manage psoriasis in children. Dr. Cadoro is a professor of dermatology and pediatrics. She's the chief of division of pediatric dermatology. She's the fellowship director for pediatric dermatology. She is also a McCallum Family Endowed Professor in Pediatric Dermatology, the co-founder of the Pediatric Rheumatology Dermatology Clinic at UCSF, and as I mentioned, a member of our medical board. Again, she really has had a lot of the vision for this program, and especially the case we'll talk through today has put a lot of thought and effort into that. And finally, we'll turn it back to Dr. Matt Stahl. He will talk about approaches to manage psoriatic arthritis in children. This is a topic that has become more and more of a focal point at the NPF. Many individuals hear of the National Psoriasis Foundation and they think psoriasis, but we really focus a lot of our energy and efforts on psoriatic arthritis as well. And in children, there's really a huge unmet need in that area, even if the prevalence may be a little lower than it is in adults. And we're very grateful to have Dr. Stahl. He is an associate professor at the Division of Pediatric Rheumatology at the University of Alabama, Birmingham. We'll end with a case and then some comments. So with that being said, I'm going to turn it back to Dr. Poller. I will let her share her slides, and I look forward to the program.
Great. Well, I'm hoping that this is the right one and that you all see now my slides. Great. Super. Well, I'm going to start with an overview of psoriasis. I want to thank Stacy for that lovely introduction. I'm very excited about this program, and I'm really thrilled about the opportunity to get together with rheumatology experts as well. Some of you are dermatologists, some of you rheumatologists, some of you are relatively newer. So excuse me if I speak a little bit in terms of some simple concepts and perhaps some that you're not aware of. So we'll start with the clinical presentation and comorbidities in children. I think we all recognize that pediatric psoriasis exists, and in fact, 1/3 of the cases in adults begin in pediatric times. This is primarily, however, a disorder of adolescence, and in contrast to other common disorders like atopic dermatitis, where there's so many in these very young children at start, it's the opposite, with a linear increase with increasing age, as you can see here, so that the majority of patients have their onset between the ages of about 10 and adulthood. You can see that after puberty, we can go up to 1.3% of individuals being affected. This is primarily a mild disorder around the world, showing here the Danish registry cohort, the Italian cohort, and recently some work we did using a claims database, US cohort, and even the Italian cohort, which has the greatest number of moderate to severe, has about 27%, and others about 13% moderate to severe. All the rest have mild to moderate involvement. Now, one of the things to recognize about pediatric plaque psoriasis is that it is commonly misdiagnosed, and there is a delay in making this diagnosis as a result. There was one study that came out of Australia in 2012 that I have referenced here, in which only 9.4% of the cases referred to their clinic that proved to be pediatric psoriasis were correctly diagnosed. Now that seems very low, but I will tell you in my own experience, it is quite common for patients to be misdiagnosed for a while by primary caregivers who recognize it as atopic dermatitis, or perhaps particularly on the scalp, seborrheic dermatitis, just a diaper dermatitis, sometimes dermatophyte infection, particularly if it tends to be a little bit more annular in appearance. One of the reasons for this is that it doesn't always look like what we're taught, that is the appearance of psoriasis in adults, with these very well circumscribed, heaped up scales. In children, it tends to be thinner. They're not as well circumscribed. I'm showing you some pictures here of some of the cases that I've seen in different areas of the body, somewhat different manifestations. I think you can see that these aren't all clear cut, and they could easily be misdiagnosed as a dermatitis or seborrheic dermatitis, and atopic dermatitis, fungal involvement of the nails, a diaper dermatitis or of some type. And in addition, I want to point out that there's more facial involvement in children versus adults with the psoriasis, overall up to 46%. And sometimes the sole manifestation with a lot of involvement, for example, on the eyelid or the face, that isn't these discrete plaques we often associate. So the term psoriasiform dermatitis has come into play for that. Now, just a little bit to be aware of course, scalp psoriasis is quite common. You may not realize that it's more common in girls than in boys. And on the other hand, nail change is more often in boys than in girls. And I think that's interesting because it brings up the concept of the Kebner phenomenon, that concept that trauma will bring out psoriatic lesions. And I would say that there's more trauma on the scalp in girls than in boys. I will tell you that I have 3 sons, and I'm not sure how often they ever combed their hair, but that's not the case with girls for sure. And nail change is more often in boys. I also like to warn patients from the very beginning who have darker skin types that we may not have the same clearance that may expect. We've got to talk about expectations here, because when psoriasis clears, it will tend to leave post-inflammatory hypopigmentation that can be quite obvious and very distressing for families who hope that with treatment, everything will go away and nothing visible will be there anymore. I want to mention diaper area psoriasis, a very common presentation in the young patients. It's also called napkin or nappy psoriasis. And this reflects the Kebner phenomenon as well. Stool, urine, a very irritated, potentially traumatized area. And one has to be aware that diaper area psoriasis is commonly misdiagnosed because it's hard to see scale in an area that's always kept moist. If I take something and I scrape a lesion, I'll often get a lot of scale, but I may not be able to see that because of the moisture. Also, when many of these patients grow up, they can still have genital region psoriasis, but a lot of times they clear and do better just because they're out of diapers and I never see them again. We need to remember as well that in children, gut tape psoriasis is more common as a presenting sign. about 30% overall, and it often follows a streptococcal infection. But a point to make is don't just think about a throat infection. Take a look at the perianal area because there may be streptococcal involvement there that is missed if you don't look. Now, what happens with guttate psoriasis that presents in these children? It may clear spontaneously in a few months, or it may persist and recur as guttate psoriasis, or about 40% progress to plaque-type psoriasis and can be more common and chronic thereafter. I'll also mention that strep can be a trigger of regular plaque psoriasis. It doesn't always eventuate in guttate psoriasis. Now, there's been some work subsequently out of Australia that was published originally, as I mentioned, with distinguishing plaque psoriasis from atopic dermatitis. And the early paper back in 2012 talked about at least one of the following: well-demarcated psoriatic plaques on the elbows, knees, lower back, guttate plaques, nail pitting, palmoplantar disease, or diaper area psoriasis as being things that you wouldn't commonly see in atopic dermatitis, but much more often and statistically significantly greater with plaque psoriasis. This same group has just put out in the last few months a very helpful follow-up where they've actually looked at the distinguishing features of psoriasiform dermatitis and noted that if at least 4 of these features are present, it really goes into the bucket of psoriasis, meaning one should treat it as psoriasis. One would need then more potent topical corticosteroids and a longer time to clear if these are seen. And I show these here. The 8 most important ones that had the most distinguishing statistical significance are history of cradle cap, history of diaper rash, post-strep or post-viral exacerbation, exacerbation with weather change, lack of sleep reduction from itch, first-degree relative with psoriasis, scalp scale, and lichenification or thickening on the elbows and knees. And then the others here, that periauricular scale or erythema, acral fingertip eruptions, genital eruption, and exacerbation with stress also were statistically significant, but not to as great a level. Now, I do want to mention this particular type of monogenic psoriasis. Of course, we think of psoriasis as a polygenic disorder, but there is a form which has also been described as CARD14 associated papulosquamous eruption or CAPE that has a very early onset, mostly in the first year of life, and does not tend to remit without treatment, but can look very much like psoriasis. It is called psoriasis, but there are often features as well, sometimes within the family of psoriasis, or a disease called pityriasis rubopylaris, also a papulosquamous disease, but with some particular characteristics like thickening of the palms and soles, and often some skip areas, not confluent erythema. Prominent facial involvement is part of this on the cheeks, chin, and ears, and usually spares the periorbital area, but not always. And usually there's truncal involvement. I'm showing you some beautiful pictures of patterning. Now, I just want to point out that boy on the left was an exception to this. He came in with what looked like an erythrodermic psoriasis. We got partial improvement that looked then more like plaque psoriasis, and he didn't present till 8 years of age, but he had a brother who was misdiagnosed as a form of ichthyosis, a scaling disorder. And when the brother came in, we realized they looked exactly alike. And this brother, who had onset at 8 months of age, actually also gave us a clue that it was a familial form, and we were able to find the gain of function mutations in CARD14. And I want to point out that these patients can also have associated arthralgias and arthritis if severe, showing you an example of a patient here with mutilating arthritis as a result of years of this without proper treatment. Now, best responses are now recognized to be from the IL-23, IL-17 inhibitor group. I also want to mention the pattern of psoriasis, or what we'll often call psoriasiform dermatitis, from TNF inhibitors. We especially see this with Crohn's disease being treated with TNF inhibitors, particularly infliximab, but others as well. But we certainly can see it as well as those who are rheumatologists, if you know, with juvenile idiopathic arthritis and other rheumatologic disorders. It does favor some areas that can look like typical psoriasis, but it can also be in areas that we don't usually see with psoriasis, like the dorsal aspects of the hand or the periorificial skin, And then there's often pustulosis associated with the palm and sole involvement. It looks often less demarcated, as you can see in some of these pictures, but it can also very much look like psoriasis. And it's hard for us to know if it's just a child with that increased risk of psoriasis by having Crohn's or JIA, who is also now coming out with psoriasis, or from the TNF inhibitor. It does not negatively affect the drug response at all. Every patient I've ever seen with this has been doing very well in responsiveness to the TNF inhibitor. Concurrent methotrexate doesn't reduce the risk, and fortunately it can often be managed topically, but about 50% need to change to another biologic that could be a TNF inhibitor or a non-TNF inhibitor. And I think it's been interesting to note that the pathogenesis is different from that of plaque psoriasis, with an induced Th1 signature, that is an interferon-driven signature, much higher than what is seen in plaque psoriasis. And I do want to also mention that we are treating more and more patients with atopic dermatitis with dupilumab to suppress that Th2 activation. And we've been seeing some patients, although it's pretty rare, with a psoriasiform dermatitis, or what looks very much like psoriasis, in the face of the dupilumab treatment for atopic dermatitis, as something else to be aware of. Finally, I want to talk a little bit about the comorbidities and the quality of life. I'm showing you this picture looking at the health-related quality of life of children with psoriasis relative to other chronic diseases, and you can see that it has a higher impact here than seizures or diabetes, and it's on a par with asthma. So a very impactful disorder for those who are affected. In fact, we're recognizing now that this can be a disorder that can be quite symptomatic. In interviews, oh, I'm so sorry. In interviews of 22 children who were 7 to 17 years of age, 61% experienced itching and 39% pain or stinging. And in a recent study of moderate to severe pediatric psoriasis, 72% of the children on a scale of 0 to 10 for itch numeric rating scale experienced at least an itch of 4 with a mean intensity of 5.3 and responded to anti-psoriatic treatment. I think, as you can see from this diagram here, there's a highly strong impact on self-esteem and social interaction of this very visible disease that can also be associated with an impact not just on the child, but on the caregiver and the family. We can see comorbidities, I'll mention in a minute, but I particularly want to mention the mental health comorbidity leading to anxiety and depression. All of this part of the embarrassment, the stigmatization, the bullying, the social isolation that these children can face that can then feed into the mental health issues. Here are just some comments from a focus group. It's knocked my confidence in my appearance. I think I'm going to have this for the rest of my life. There are things I want to do that I can't do. I hate it because everyone can see it on my face, and I always will suffer low confidence. But even in those patients with mild psoriasis, 65% report experiencing social stigmatization, 50% being bullied or called names, and 27% feeling ashamed of their skin in a study in the last 10 years. This is what we see with respect to the psychiatric comorbidities. And you'll see in particular that increased risk of any psychiatric comorbidity, and particularly anxiety, bipolar disease, but certainly a numerically increased risk of depression as well. So finally, look for comorbidities. We're going to hear a lot about juvenile idiopathic arthritis, the so-called psoriatic arthritis, in a minute. So I don't want to say too much about that, except that we, as dermatologists, are not very good at doing joint exams, and yet we should do at least a screening evaluation. I have my joint rheumatology, dermatology clinic with 4 pediatric rheumatologists. They've taught me a tremendous amount. And so we put together this evaluation. If you're a dermatologist, take a picture of this QR code right here and incorporate it. It takes less than a minute additionally, because when you're doing the skin exam, you can also be feeling and moving around joints and doing this very rapid evaluation that sorts out, is this arthritis, or is it something very common like hypermobility or a sports-related issue? I'm not going to talk about uveitis except to say it's largely seen with arthritis, and we'll hear about that more later. Inflammatory bowel disease, especially increased risk for Crohn's, and then what we see most commonly, and that's the obesity and soft increased risk of metabolic disease. This is greater in the US than other countries, and beyond just the greater obesity that's seen, suggesting the environmental influence. The obesity does correlate with increased severity. And in a study that we and some others did a few years back, we found that if one looks at the group that's overweight or obese and dials back to 2 years before the onset and diagnosis of the psoriasis, and then continues to look thereafter, 2 years before, those patients who at this point had obesity or overweight status were obese or overweight in 92 to 93%. It was that way at the time of the psoriasis. It persisted at least 2 weeks after, 2 years after rather, suggesting that indeed the obesity precedes the psoriasis in the majority of patients. And therefore the psoriasis is something we need to think about in patients overall in this pediatric range with obesity. It's been shown that psoriasis is an independent risk factor for metabolic disease, although it has a smaller effect than the obesity. And Winnes Tom has shown abnormalities in lipid function, including after adjustment for body mass index, and also regardless of the severity of the psoriasis. And finally, I want to point out some wonderful studies that were just published in the last few years that provide guidelines for the recommendation for associated comorbidity screening. What I'm showing you here from the American Academy of Dermatology's guidelines, but you can see the list in addition to being overweight or obese of hypertension, dyslipidemia, diabetes, non-alcoholic fatty liver disease, arthritis, gastrointestinal disorders, and polycystic ovary syndrome. And with that, I want to thank you for your attention. I'm going to stop sharing my screen and let others take the floor.
So I think just out of respect of time, we will move on and we will return for more questions. If you do have questions, please, I encourage you to put them into the chat function. And with that, I will turn it over to Dr. Lawson to talk about psoriatic arthritis in children.
All right, thank you so much, Stacy, and thank you all for having me today. So psoriatic arthritis in childhood is a form of juvenile idiopathic arthritis, commonly called psoriatic juvenile idiopathic arthritis. So to step back a little bit to the diagnosis of juvenile idiopathic arthritis. So this is arthritis, inflammation in a joint with onset prior to age 16. It has to go on for at least 6 weeks, and there's no alternate etiology, such as a Lyme infection or a post-streptococcal etiology. Psoriatic GIA is a relatively small subset. It represents about 7% of all GIA. And of note, it's among the most heterogeneous and some would even say problematic subtypes of GIA. And I'll talk a little bit more about that. So what are the clinical findings of GIA especially for our dermatologists out there? So we have a picture here of a patient with a generous looking right knee. And this is the kind of arthritis you can see across the room, but it's not always that way. So joints, especially the large ones, are often warm. Stiffness is a really characteristic feature. So when you move the joint back and forth, there's just more resistance than you would expect. That may come with pain, but not always. There's often swelling, which again, may or may not be obvious. Patients may limp, especially in the morning. It's notable that the pain of arthritis is typically not severe. It's more of an ache, but it's not usually a sharp, screaming, super acute kind of pain. Symptoms are often worst in the morning. And I would say this, if you're going to ask your patients one question about their joint disease to make a decision about whether to send them to the rheumatologist, this is the one I would ask, is if their symptoms are worst in the morning. A lot of causes of joint problems will cause worse pain with activity or towards the end of the day, but that increased stiffness in the morning and increased pain in the morning is really suggestive of inflammatory rather than mechanical disease. So these are the ILAR classification criteria for psoriatic GIA. The ILAR criteria are the subsets of GIA that we use most commonly these days. So the first one is simple. You can have psoriasis and arthritis in order to qualify as psoriatic GIA, or you can have arthritis and 2 of the following. And these can be nail changes, typical of psoriasis, typically pitting. It can be dactylitis, which I'll show you some pictures of in a moment, or psoriasis in a first-degree relative, and that includes parents and siblings. So these are some pictures here of nail pitting. Here's another picture. And you can see a little onycholysis here near the nail bed. And this is subtle. So you can see these pictures are really zoomed in. It's often helpful to take an otoscope to try to get a little magnification and some extra light. And here's an example of dactylitis. So this is digital swelling that extends beyond the joint. So you can see here, this entire finger is swollen. It's caused typically by tenosynovitis, so inflammation not just of the synovium, the tissue inside the joint, but also the tendons that run the length of the digit, as well as enthesitis, so inflammation at the place where those tendons attach to the bone. And you can get subperiosteal bone growth, so the bones actually get bigger, that can lead to a chronically larger appearing joint, or I should say chronically larger appearing digit. Here's another example of what's called a sausage digit. So you can see this fourth toe here is swollen all the way from the base to the tip in a relatively linear way. Dactylitis also in our, as we saw more in our previous picture, could be more what's called fusiform, from extending from a more tapering or narrow appearance and then fatter towards the middle. So I alluded to the fact that there are really two subtypes that we see clinically in psoriatic JIA, and they have different ages of onset. So children who have early onset of psoriatic JIA typically start with their symptoms in preschool. This subtype is more common in girls. And clinically, it's closer to oligoarticular JIA, which is 4 or less joints inflamed, often seen in young kids of the same age group, or rheumatoid factor negative polyarticular JIA, which is 5 or more joints in a similar demographic. There is often dactylitis, and one thing that's different from oligoarticular JIA is that wrist and small joint involvement is pretty common, although unlike RF negative poly JIA, which tends to be more symmetric, psoriatic JIA is more likely to be asymmetric. The late onset subtype tends to start up in adolescence, and this subtype is about the same incidence in boys and girls, and looks clinically more like adult psoriatic arthritis or enthesitis-related juvenile idiopathic arthritis, which we sometimes call ERA. So this subtype is characterized by more prominent enthesitis, inflammation at the tendon insertions. We see this often in the feet and sometimes in the pelvis and around the knee, and can be quite painful, especially with activities. These patients are also more likely to get axial disease with sacroiliac or spinal arthritis, as well as hip arthritis. So the joint involvement is typically oligoarticular presentation, usually starts with not as many joints. Common locations are the knees, ankles, hips, wrists, and small joints of the hands. In particular, the distal interphalangeal joints, DIPs, the last joint in your finger, involvement of that joint is particularly suggestive of psoriatic JIA. There's sacroiliitis, so inflammation where the pelvis attaches to the spine in about 10 to 30%, and those patients are more likely to have a positive HLA-B27 antigen test. Inflammatory disease of the lumbar spine can be seen, but pretty uncommon in less than 5%. And enthesitis, as mentioned, is really more common in this adolescent subgroup. So only seen in about 1/4 of the younger kids, but more than half of the older kids. Dactylitis is seen in about 20 to 40%, and the most common sites are the index finger and the second toe. With regard to skin and nail involvement, somewhere around 1/2 of children will have overt psoriasis, but even more may have those subtle nail changes. So it's worth looking for those if you have a patient who presents with arthritis and you're trying to figure out if they could be psoriatic. So let's talk a little bit about uveitis. So this is in the younger subset. They are more likely to have chronic asymptomatic anterior uveitis. We see that in about 10 to 15%. And we do know that if they have a positive ANA, that increases their risk for uveitis. So those kids need to be screened a little more frequently. And the screening for uveitis is done with slit lamp exam. The older subset is more likely to have acute anterior uveitis, and a positive HLA-B27 antigen increases this risk. So just to review the anatomy of the eye here, because I know this stuff can be hard to remember. So anterior uveitis is inflammation in that front part of the eye between the cornea anteriorly here and the iris posteriorly. And this inflammation is mostly due to inflammation of the iris. So we look for uveitis by looking into this anterior chamber here for inflammatory cells. And here on the right at the top, you can see a normal, the normal anatomy here. So you have your cornea, you have your iris, you have your ciliary body. And then on the bottom is an example of uveitis. And here you can see there are lots of inflammatory cells and debris hanging out in that anterior chamber around the iris and around the ciliary body. So let's talk a little bit about the differences between chronic anterior uveitis and acute anterior uveitis. So this chronic anterior uveitis is the type of uveitis that we're more likely to see in the younger kids. And the important thing to know about this is that it's often completely asymptomatic, which is why screening is so important. So this is an example here where this child has developed adhesions between the cornea and the iris, what are called posterior synechii, causing this irregular shape of the pupil. But the eye can appear completely normal. And this is in contrast to acute anterior uveitis. So this is the subtype that we're more likely to see in our older kids who are HLA-B27 positive. And these kids will present with a red, painful eye, often with photophobia. So this is a lot harder to miss, although you can note that the pupil here is also irregular due to posterior synechii and chronic inflammation. So how do we use our laboratory findings in psoriatic JIA? Laboratory findings can be supportive, but you cannot exclude or establish the diagnosis with lab tests. That's really important to recognize that this is really a clinical diagnosis. If inflammatory markers are elevated, that can be supportive, specifically the SED rate, the CRP, or platelets, but they may be normal, and that does not exclude arthritis. Similarly, the positive ANA is really only useful to determine uveitis screening frequency. So there's about 60% of the younger subset will have a positive ANA, 30% of the older subset, but it is not a diagnostic test. So it doesn't tell you whether this is what they have, or even if they have an autoimmune disease. And then rheumatoid factor in these patients is typically negative. With regard to radiologic findings, on X-ray, with long-standing disease, you can sometimes see bony changes or joint space narrowing. Proliferative new bone formation is really common in adults, but we don't see it as often in children. But again, much like the lab test, abnormalities on X-ray are supportive, but they do not confirm a diagnosis, and kids with arthritis can have completely normal X-rays. MRI, on the other hand, can be more useful, especially if the joint exam is equivocal or if you want to take a closer look for sacroiliitis. So on MRI, if there is arthritis present, you will see abnormal findings, specifically synovitis, so inflammation of the tissue inside the joint, effusions, tendinitis, inflammation of the tendons, enthesitis, and bone marrow edema. Similarly, ultrasound can be really useful. It can be done bedside as opposed to MRIs, which are more expensive and usually more difficult to schedule. So this also allows visualization of synovitis, effusions, tendinitis, and enthesitis, as well as the ability to do serial exams, so to be able to follow changes over time. And then these are some examples here. You can see some radiographs and an example here of that periosteal new bone formation in a child with dactylitis of that left third digit. And here are some MRI images in an 8-year-old girl with psoriatic JIA. So for image A, this is a coronal stir sequence that shows lobulated fluid signal along these flexor tendons of the 4th digit. So this synovitis here lighting up due to the inflammation. Similarly below, this is an axial post-GAD T1 weighted fat saturated image that shows enhancement around the flexor tendons of that 4th digit. So again, the tenosynovitis. And then these are some MRI images of a knee effusion. So this is a girl with recurrent right knee swelling and pain. Image A is a sagittal T2 weighted MRI with a large effusion. So you can see all this bright stuff up here is fluid that doesn't belong there. And then this is the post-GAD image over here. And you can appreciate here's the synovium inside all lighting up. All right, so if we're considering psoriatic arthritis, what else is on the differential? Well, certainly other forms of JIA in the younger subset, that could include oligoarticular or RF negative polyarticular JIA commonly. The older subset with sacral ileitis and enthesitis could have enthesitis related JIA if they don't meet criteria for psoriatic JIA. Patients with large joint oligoarthritis, depending on where you are in the country, you may need to rule out Lyme disease. Also consider post-streptococcal arthritis and reactive arthritis. For acute onset polyarthritis, consider also reactive arthritis following an infection. Parvovirus B19 is a particular culprit here in acute onset polyarthritis. For patients who have fever, severe pain, and night pain, think about some of our more serious diagnoses that you would want to consider very quickly. So for acute onset in one joint, septic arthritis should be considered. With a more chronic course with more joints involved or a migratory type presentation, think about leukemia. Again, to emphasize, we really don't typically see severe pain or pain that wakes you from sleep in our arthritis patients. And if your patient is reporting those kinds of symptoms, that's a red flag to go look for alternate, more serious diagnoses. With regard to dactylitis, other things to consider include sickle cell disease, tuberculous osteomyelitis, and sarcoidosis, although these would be rare alternate causes, are other things that can cause dactylitis. So in summary, some clues to diagnosis. Think about a family history of psoriasis, so make sure to ask about that in your arthritis patients. Any suggestive rashes, and as Dr. Powler emphasized, they can sometimes be subtle or easy to confuse with atopic dermatitis. Look for nail pits or onycholysis, dactylitis, so not just swelling of the joint, but swelling of the whole digit, oligoarthritis affecting small joints, as well as enthesitis. And then this is just an example here of some scale and cracking. It's a little hard to see behind the ear of a child with psoriatic JIA, so super subtle early psoriatic findings. So in summary, psoriatic JIA is a subtype of JIA. Only 50% of kids will have psoriasis at diagnosis, so there are other clues that you need to look for. There are two main subtypes: early onset with disease onset in the preschool years that resembles oligoarticular or RF negative poly JIA, and late onset, which tends to occur more in adolescence and resembles adult psoriatic arthritis or ERA. Lab findings are supportive, but not diagnostic. And uveitis is an important comorbidity, and you need to get screening slit lamp exams to keep an eye out for that.
Thank you so much, Dr. Lawson. Outstanding presentation and lots of really great information. Any questions? Okay, again, just a reminder, please feel free to put them in the chat as desired. And now it's my pleasure to turn it over to Dr. Kelly Codoro, who's really serving as the chair of this event. And again, like I said, has put so much energy and thought into it. And we really look forward to hearing her thoughts on systemic therapies for pediatric psoriasis and really, you know, what is in our toolbox, what can we do to manage psoriasis within these kids. Thanks, Kelly.
Yes, Stacy, thank you so much. Can you hear me?
Yes.
Okay. I want to thank Stacy Bell in particular for spearheading this effort and engaging me to do this. I want to thank Shiva Mozaffarian from the National Psoriasis Foundation, who's really managed all the logistics for this event. And of course, the fabulous panel of faculty that we're all benefiting from learning from today. So thank you so much for this effort. It was definitely a team effort. I'd like to talk about systemic therapy for pediatric psoriasis, which means therapies that are either taken as pills or injections to treat more moderate to severe types of psoriasis. And first, I'd like to just, important to disclose, I have no financial or other conflicts of interest related to this talk. So when I talk about different drugs, it's because they are what is available, but many drugs are still off-label, meaning they're not FDA approved for treatment in children, and I'll discuss some of those as well. And my goals then will be to talk about therapeutic selection, and this involves consideration of many factors, including severity, how severe the disease is in a child, and whether or not they have the presence of triggers or other comorbidities, and how we make these decisions. Dr. Paller alluded to this, but I'd like to point out that the National Psoriasis Foundation and the American Academy of Dermatology came together and created a treatment guideline, a series of guidelines. And for the first time ever, we have enough data and expert consensus to develop a pediatric psoriasis treatment guideline. And Dr. Paller was one of the authors of this important guideline. And because today is not meant to be exhaustive, I would like to direct your attention to the guideline, which includes these 6 sections with much more detailed information than what can be presented today about psoriasis and its treatment. So, sometimes psoriasis shows up in a mild to moderate presentation, as is the case with the 6-year-old with very localized scalp, back, and leg psoriasis. And that may warrant a specific type of evaluation and treatment. And sometimes psoriasis shows up like this, where it's almost full body surface area, as presented in this 10-year-old boy who had come into our pediatric rheumatology dermatology clinic at UCSF after having failed therapy with various creams and ointments and phototherapy. We're going to discuss 2 cases just like this at the end when we have our panel discussion about clinical combined approach to these patients. So stay tuned for that. I'd like to point out that psoriasis is an auto-amplifying inflammatory cascade that involves both the innate and adaptive immunity. So our early immune responses and then our late immune responses. And the components of the immune cascade or the inflammatory cascade then become the treatment targets. So in this diagram, we see the keratinocyte, which is a skin cell. It overgrows, it thickens, and blood vessels make it very red, so you see the plaques of psoriasis. And in order to reduce that growth or proliferation, we can use medicines such as the oral retinoid therapies or phototherapy. If we're trying to combat the cells, the T cells and the neutrophils and the dendritic cells that come in and amplify the signal and make the psoriasis worse, we can use systemic therapy such as methotrexate, cyclosporin, and also phototherapy. And these are the more traditional forms of therapy. More recently, there's been a tremendous explosion of information about the real drivers of psoriasis, which are the cytokines or the inflammatory highways that can be blocked by medicines called the biologics. So molecules such as TNF, interleukin 17, interleukin 12 and 23 contribute to this amplification cycle and can be blocked. Some of the work that Dr. Mike Rosenblum and I did at UCSF showed that pediatric psoriasis patients may have an overactive interleukin 22 pathway, and we do not yet have an interleukin 22 inhibitor to treat pediatric psoriasis, though this is in the works. So there's multiple targets to use. And the traditional approach to treatment of psoriasis is to think about it as in the form of a ladder. When the patient has mild condition, we might use topical ointments and lotions and creams. As they progress, we may reach for phototherapy such as narrowband UVB or UVA with Sorlin called PUVA. And then only as as the psoriasis got much worse, would we consider a systemic immune suppressive therapy or even a biologic, an injectable immune modifying therapy. And most importantly, I'd like to share that kids are undertreated. Way back in 2012, we understood from reviewing the literature that less than 1% of pediatric psoriasis patients in this country were treated with a systemic therapy. And we know that more than 1% have moderate to severe disease. And then when we undertreat kids, we risk their development of medical comorbidities and psychological comorbidities, as you just learned from Dr. Paller, and also potentially developmental and psychosocial consequences. So I would invite us to rethink the therapeutic ladder, because occasionally when a patient comes into our clinics, we need to start right at the top of the ladder with a biologic, and occasionally we need to start at the bottom with a topical. And those treatment choices have many different factors to consider. The tools available then to manage, on the most part here, I'm talking about more moderate to severe plaque psoriasis in pediatric patients, can be thought of as in a couple of different buckets. One are the tried and true systemic immune suppressive medicines, on the left in this box. These are the 3 medicines that we used almost exclusively together with phototherapy before we had newer technologies. The newer and novel therapies are the biologic, as I just mentioned, the TNF inhibitors, the 12/23 and the IL-17 inhibitors. And there's also an oral formulation, not yet approved for kids, that is a phosphodiesterase 4 inhibitor, which is also an inflammatory pathway. We occasionally dip into miscellaneous treatments such as antibiotics if we find infection, tonsillectomy in kids who have severe recurrent gut tape psoriasis with streptococcal tonsillitis, and weight and diet recommendations are always appropriate for our patients who are overweight or obese. And then complementary and alternative medicine occasionally comes into play as well based on family preferences. Now, we have fairly little data to guide decisions between treatments. We don't have a lot of this treatment versus that treatment showed this and that. So we often have to make decisions based on individual factors and what we know about individual medications. And we want to, when we make decisions about treatment, account for the risk of the medications themselves, but also the very important risk of under or untreated disease, and take into consideration family preferences. So we often have to think about what is our threshold for use of systemic therapy. Can you give an infant a systemic therapy? Well, it really depends on the age and the developmental stage in the clinical scenario. So yes, you can treat an infant with a systemic or biologic immune modulating therapy, but you may not always need to. When we see newborns and infants with psoriasis, we really think about triggers. Is there something in the environment? Is there a monogenic disease? Dr. Powler talked about card 14. Are there others which can cause pustular psoriasis in kids? And we try to take a conservative approach when we can. When older children and adolescents get psoriasis or have it, we consider that important medical and psychosocial impact that was discussed earlier, and whether or not there are comorbidities which might drive us into treating in a specific way. When we think about the physiology in teen patients, that's very, very similar to adults. However, psychosocially and emotionally and cognitively, teens are very much more similar to children. So we really have to balance the approach to their emotional state with their physiology based on age. Importantly, when we're thinking about severity, we want to not only think about objective measures such as body surface area of involvement or PASI or global assessments. We want to really think about how much body surface area is involved, but also the subjective measures, what the patient is telling you, or what you infer the impact may be based on sites of involvement. So newer severity representations are considering both objective measures and subjective. So this is an example of 2 different patients who by objective measures would both have mild psoriasis, a couple of percentage of body surface area involvement. But we know on the left, this child is stigmatized, he's bullied, he's withdrawn socially because of the location. And this child on the right cannot hold a basketball, can't put a hand in a mitt, can't do sports, has a hard time doing theater, tumbling, you name it, even though the hands and the feet are the only involved areas. Both of these children have high impact sites and therefore would be considered severe and would be considered to be treated with systemic therapies. Now, it's really important to look for strep infection because strep can trigger psoriasis by sensitizing those T cells, the immune cells that lead to the overgrowth of the skin tissue cells. And these are examples of strep tonsillitis on the left, anogenital strep, where you can see erosions and fissuring of the anus, here of the vulvar skin, and here of the scrotal and penile skin of a young boy. We want to culture these with a swab, and if we find strep, we should treat it. And this may also impact our decision to be aggressive. We may withhold systemic aggressive treatment for the psoriasis until the infection resolves and we see how the psoriasis sorts itself out. So when you find a trigger, if you can treat it, it might modify how you're going to approach the condition. Dr. Pallard gave a beautiful overview of comorbidities, and I only show this slide to say that it should always be part of the consideration about what medicine should be used, whether a patient has obesity, arthritis, or a mood disorder. We also consider when we're thinking about how to treat psoriasis, do we want to use an immunosuppressive or an immune modulatory treatment? And certainly we're using less immunosuppressives in the era of COVID. How about lab monitoring, which requires a blood draw, which can be very difficult for kids? Does the drug require a lot or a little lab monitoring? Can the patient take an oral formulation, or is the medicine only available in a shot? Is the therapy feasible? Can they access it? Is it logical for the patient, depending on their medical history? Is it safe? And certainly cost plays a big role when we're thinking about therapy. The most common question we get asked about psoriasis in children is which drug to use for which patient. And the truth is there's no one right answer, except in the case of certain comorbidities, certain contraindications, and some genetic variants. So when a patient has psoriatic arthritis, we will talk about this later, we often reach for something like methotrexate and a biologic therapy. If a patient has inflammatory bowel disease, we try to avoid IL-17 inhibitors, which can make IBD worse. Liver and kidney disease might impact which drugs we choose, and we want to avoid methotrexate and cyclosporin. Females of childbearing potential who have started their menses, we want to avoid the oral retinoids because of their teratogenic effect. And then some of the medicine, some of the genetic subtypes like CARD14 associated psoriasiform eruption, we may reach for an IL-12/23 inhibitor, which seems to have the best data to date, or a monogenic inflammatory disease like deficiency of IL-1 receptor antagonist, we'll look for a recombinant IL-1 receptor antagonist to treat. So there are just a few choices, but otherwise it really is based on the art of medicine and the science that we have access to. So a few summary slides here. The tried and true therapies still play an important role. These systemic therapies act broadly. We don't really have randomized controlled trials or approvals, but there's decades of experience with methotrexate, which works. Cyclosporin is very fast. Acitretin is non-immunosuppressive, and phototherapy is very good if there's access to it. And the advantage here is that they're easy on and easy off. The targeted therapies, such as the biologics, are accumulating data. Dr. Pallard did one of the first big studies in children with TNF inhibitors and proved their efficacy. They were the first drug to be approved, etanercept. We also have IL-12/23 and IL-17 inhibitors approved, and we're accumulating data in trials with other drugs. The biologics have reassuring safety profiles, and really the expectation now is near or complete clearance of psoriasis. So when we reach for a biologic, we know they're rapid, they require very few labs, but it's really important to update vaccines before we use any immune suppressive or immune modulation. And these drugs can be immunogenic, and we'll talk about this later with our rheumatologists. Anti-drug antibodies can decrease their efficacy and increase the risk of drug side effects. So occasionally we start with methotrexate and think about allowing the drug to last longer and have more effect in that context. These medicines, again, are expensive and often require step therapy, meaning you often are required to start with a different medicine before you're allowed to prescribe a biologic. Finally, I'll say that the challenge is endpoint. When we start a biologic therapy, it's hard to know when to stop it. And occasionally we often will think about using conventional systemics in a 3-phase management where we clear the condition with the systemic, we transition the patient to the lowest effective dose or off of the medicine and maintain them either on topicals or phototherapy or a low dose. And when they flare, we go back and repeat. However, with biologics to date, we typically think about continuous therapy, so we don't have anti-drug antibodies. However, recently there are some data in adults with successful use of intermittent biologics. So with that, I will end by saying all of these drugs have variations in required monitoring. I did not have the time to think about that. or excuse me, talk about that. So please look at the guidelines that has dosing, monitoring tables, and other considerations. So we will come back to these cases at the end of this session, which will be interactive, and you'll hear from the rest of the panelists. So I want to thank you very much for your attention, and I'll turn the stage over to Dr. Stahl.
Any other questions? Again, don't hesitate to use the chat. We will have time at the end for more discussion. I would like to just add a couple of things that I'd like to return to, Dr. Codoro. Your commentary about IL-22 is extremely interesting, so I think it's going to be something for us to keep an eye on. As you mentioned in your talk, you know, there are many similarities, especially for teenagers to adults, but yet there are others that they're still very much in their childhood phase. And so I think that, you know, in the development, that happens both mentally and physically. So I think possibly having other targets in the pediatric population is going to be really important. I think the other thing, which, as you know, is extremely important to the National Psoriasis Foundation right now, is to really think about severity and how that is being measured beyond the objective measures of PASI or body surface area. And I think this is extremely important in the pediatric population. Particularly because many of the things that are set, whether they be you know, mental health issues, obesity, et cetera, really in childhood set the foundation as those individuals move toward adulthood. And so I think that really all working together to define that's going to be extremely important. With that being said, I'm now excited to turn to the treatment of psoriatic juvenile idiopathic arthritis. Dr. Stahl, if you wouldn't mind taking over, we'd love to hear from you.
Okay, well, I would like to thank the National Psoriasis Foundation for the invitation. So I'm scheduled to do some consulting for Novartis, and I will speak to off-label therapeutics. You have to in this field. So there are lots of drugs approved for psoriatic arthritis in adults. Of those, one of them is approved for psoriatic arthritis in children. Part of it is strategic. It depends on what we call it. So if we call it JIA, now we have a decent handful of drugs. There are others that are approved for JIA, but this is among those that are approved for psoriatic arthritis in adults. If we call it psoriasis, as we heard earlier, there are some different pathways, different mechanisms that are approved in children. If we call it juvenile psoriatic arthritis, the only drug we have approved is golimumab. Nothing against this treatment, but it's nice to have options. So why is that? Well, there's not a whole lot of prospective data in children with psoriatic arthritis. There are two prospective studies, the CLIPPER etanercept registry and the Junipero randomized trial that has not yet been published, but it was presented at EULAR and will be presented at the ACR as well. So the CLIPPER study was an open label study of children with extended oligoarticular JIA, psoriatic arthritis, and ERA who were treated with etanercept. The psoriatic patients were all 12 to 17 at baseline with a short disease duration. So you heard earlier about the early and late onset psoriatic population, and these were all late onset. The initial outcome assessment was performed at 12 weeks with long-term follow-up, most recently published in 2019 at 6-year data, and the ACR will present some safety data at 8 years. So they all got better very quickly. And you can see that over here within 12 weeks, all three groups, extended oligoarticular, ERA, and psoriatic JIA were all improved. These are various control groups. This was not a controlled study, but other controls did not improve as quickly over 12 weeks. And this is sustained over 6 years. Again, in all of the groups, you can't distinguish which is which. Next is the randomized controlled trial of secukinumab in children with juvenile spondyloarthritis. This was a withdrawal phase study in 97 children with ERA or psoriatic JIA. All patients received open label secukinumab for 12 weeks. Responders were randomized to secukinumab versus placebo for up to 100 weeks. And this is a standard study design in children with JIA, so that they're not exposed to placebo for extended periods of time. And the primary endpoint was the time to flare, so that if they do flare, then they're immediately transferred over to the study drug. This data was presented at the EULAR conference over the summer. And this is shows some promising results. Here, this is time to flare. And this is days, this is the proportion who had a flare. So this is a placebo group. This is the 2 spondyloarthritis groups combined. And you can see that the hazard ratio, the risk of a flare was a lot lower among those treated with study drug versus those who were given placebo. This data is available online at the ACR Open Access. The abstract is available. The data itself has not been presented at the ACR, but I'm told that because this is available, that I'm allowed to present it. And this study, or this slide rather, then shows that both subgroups, the ERA and the psoriatic JAA, had very similar responses compared to each other. This particular slide does not show the control group. So I mentioned that golimumab is approved for psoriatic JAA. And why is that? Since there's no randomized controlled studies of golimumab in this population. And this is an important lesson that may be a pathway forward for other therapeutics. This was a study of golimumab IV in children with JIA. And this is an open label study. They improved over time. The main outcome here was, well, they improved, but trough concentrations. So this is a trough in 3 different groups, age-based groups within this poly-JA population. This is combined. This was the trough levels in 2 different RA populations. And so based upon this, they're able to get the approval, the indication for JIA as a whole. Now, among the children who were in the study, 5 of them had juvenile psoriatic arthritis. Despite the small numbers, the manufacturers were able to argue that there's not a meaningful difference between psoriatic arthritis in adults and psoriatic arthritis in children. So therefore, they were able to get the indication in childhood. And that's it for prospective studies. And so we extrapolate. We take data that's been done in adults, and we, to the best that we can, apply it to children, especially if they do have a similar phenotype, and use the drugs in children. So you heard earlier that there are some age-based differences within this diagnosis, where early onset JAA is different than late onset. And every 10, 15 years, someone publishes a graph that looks like this, where you see a peak of onset at age 2 to 3 that we also see in JAA as a whole, and then a second peak later on in life. And as you heard, so I won't dwell on this, late onset psoriatic JAA resembles spondyloarthritis, early onset resembles other categories of JIA. So the treatment of early onset psoriatic JAA. In the absence of data to the contrary, and given legitimate questions as to whether or not this even represents spondyloarthritis, since they don't have enthesitis as much, they don't have acute anterior uveitis, they have, and they do have positive ANAs frequently, they have the chronic uveitis. So it seems reasonable to treat early onset psoriatic arthritis similarly as you would oligo and polyarticular JIA. And we published some treatment guidelines a couple of years ago. And I'll summarize those. So methotrexate is recommended as a first-line therapy. TNF inhibitors are recommended for patients with inadequate response to methotrexate, and we did not have a preference among the individual TNF inhibitors. If there's no response to the first TNF inhibitor, we recommend switching to a different mechanism of action. And the drugs we spoke to specifically were abatacept and tocilizumab. This was before the tofacitinib received an indication for JIA. Now, the important thing here is so far, the first part of the slide would have applied to late onset psoriatic arthritis for the most part. However, abatacept and tocilizumab are not therapeutics that we use very much or that are used very much in adults with psoriatic arthritis, nor am I going to speak to them a whole lot for children with older onset psoriatic arthritis. So this is specific to children who are 2-3 years of age who meet criteria for this condition. So treatment of late onset psoriatic arthritis. And in 2015, GRAPPA published some treatment recommendations. I'm not going to speak a whole lot to them because they're a little bit dated, but an important concept here is a concept of domains of psoriatic arthritis. And they spoke to enthesitis, peripheral arthritis, axial disease, dactylitis, nail disease, psoriasis, and they gave special mention to uveitis and IBD, which I think in children, I would argue that uveitis is more than special mention, but is a really key part of this disease that we need to take into account. So why is this concept important? Because different disease features do not respond equally well to therapies. Therapeutics that are highly effective in one domain may have no effect or even worsen a second. And so sometimes we have to work with the patient to determine which feature is going to drive the bus. And you'll see some illustrations of that with the cases later on. So these are some illustrations that I'll speak to as well, some examples where different therapeutics don't work equally across the domains. IL-17 inhibition particularly benefits psoriatic skin disease. So this was a head-to-head trial. There aren't that many such trials. This was a head-to-head trial that Filmbeats published in 2020, comparing ixekizumab, which blocks IL-17, to adalimumab, which is a TNF inhibitor. The two outcomes that were presented on this slide are the ACR 50, which rheumatologists are familiar with, and it speaks to improvement in domains specific to arthritis for the most part, and the PASI 100, which means 100% skin clearance. So for the ACR 50, you see very substantial overlap between the two therapeutics that had equivalent effect. For the PASI 100, you see spread as early as 4 weeks out, you see spread favoring IL-17 inhibition over TNF inhibition. IL-17, but not IL-23 inhibition, benefits axial disease and ankylosing spondylitis. This is a study of secukinumab, which blocks IL-17, and you see higher or more responders among those who received study drug, 2 different doses of study drug, versus those who received placebo. On the other hand, there are 2 different studies that involve drugs that target IL-23. One of them targets an antibody directly against IL-23, the other blocks IL-12 and 23, ustekinumab. And for both of these studies that came out in the past 2-3 years, you look at the outcome, and it doesn't really matter which line represents which drug or which dose, because there's no difference at all here and here. Now, there are questions been raised recently as to whether or not IL-23 inhibition treats axial disease and psoriatic arthritis. This is the BASD response, which is a composite outcome that measures 6 different outcomes relevant to axial spondyloarthritis. And you can see this is a study in patients with psoriatic arthritis, psoriatic arthritis in general. And among those who had axial disease, they reported improvements in the BASD that were greater among those receiving ustekinumab as compared to placebo. And there are 2 studies. This is 2013. There was a more recent study that had a similar outcome. So before we necessarily jump to the conclusion that IL-23 inhibition is going to be effective in axial spondyloarthritis, axial psoriatic arthritis, we're going to need some prospective data that specifically addresses that question. There's an editorial that came out within the past month or 2, where the authors argue that we need to be very cautious with how we interpret this data. First of all, these are post hoc analyses, so automatically we need to take this with a grain of salt. Importantly as well, the BASD is not validated in psoriatic arthritis because the BASD has a number of outcomes that are clearly going to be improved when you treat the disease, including peripheral disease, heel pain, and enthesitis, that may respond better to, or that may reflect improvement, therefore, in the peripheral disease. Even improvement in back pain may represent improvement in the peripheral disease insofar as the patient overall is feeling better. Their skin disease is better, their peripheral joint disease is better, their enthesitis is better. There may be some central sensitization that is resulting in improvement in the back pain. So we need prospective studies with imaging outcomes before we can really say for sure or address for certain whether or not IL-23 inhibition is going to be effective in axial psoriatic arthritis. So the last few slides, you might conclude, well, let's use IL-17 inhibition in anyone, in everyone. But as you heard from the previous slide, IL-17 inhibition does not work in Crohn's disease. To the contrary, it is actually highly ineffective to the point where you're better off getting placebo than being treated with IL-17 therapeutic. There are 2 studies based upon which we can reach that conclusion. This studied brodalumab, which targets IL-17 receptor. And this is a percent with worsening disease. You can see placebo, just 3 out of 32, whereas 3 different doses of the study drug, a much greater percentage of the patients had worsening disease. Likewise, with the secukinumab study, IL-17 antibody against IL-17A, the outcome here is CDAI, Crohn's disease activity index. And if you look at these 2 lines, this was the study drug, this is placebo. Very substantial differences here. Had this been swapped, we probably would have an indication for secukinumab and Crohn's disease, but unfortunately, this means the study drug did worse than placebo. Etanercept, as most rheumatologists are aware, is ineffective for certain complications of JIA, including Crohn's disease, shown over here. This is a study that showed no benefit of etanercept compared to placebo. And this is a small study in uveitis. So to summarize domain-based therapy, traditional DMARDs such as methotrexate are effective for inflammatory bowel disease, they may be effective for peripheral spondyloarthritis. They are demonstrably ineffective for axial SpA. You heard about them for psoriasis, also work in uveitis. Etanercept does not work for IBD uveitis, does work for these other indications. The TNF antibodies such as adalimumab and infliximab work across the board. They're terrific first-line therapy for just about anyone. Anti-IL-17 therapeutics are ineffective for IBD. They work for peripheral and axial SpA as well as for psoriasis. There's not a whole lot of data for these other therapeutics for uveitis. Anti-IL-12 or 23, such as ustekinumab, they work for IBD and peripheral spondyloarthritis, are ineffective for axial. They also work for psoriasis. Again, there's not a whole lot of data for uveitis. Integrin receptor inhibitor vedolizumab is one drug, maybe I think it's the only drug that does this. It's approved for inflammatory bowel disease, not studied in these other indications. It blocks T cells, inflamed T cells from entering into the gut. So most likely it's not going to work very well for these other indications. And there are case reports of patients who developed arthritis flares while on veto. Finally, JAK-STAT inhibition may also work well for many of these indications, although it's a newer therapy and remains to be seen what it'll do in pediatric SpA. So what about combining biologics? So if you're a fellow and you're taking the boards, that answer is incorrect. And this is based upon some studies quite a few years ago showing an increased infection risk among patients taking etanercept and anakinra for RA. More recently, AbbVie, the manufacturer of adalimumab, generated a bispecific drug that targets both TNF and IL-17, and they trialed that in both psoriatic arthritis and in RA. So this is what they found. Point first to the safety, because I think this is more important here. When they looked at adalimumab by itself, placebo, and 2 different doses of the study drug, the safety events were very similar across the board. And that's a hugely important point. That means that it can be done safely. Now, when you look at the effectiveness, this is placebo. These are the adalimumab by itself and the bispecific inhibitors, 2 different doses of the bispecific inhibitor. And there's really no difference in effectiveness. So AbbVie lost interest in this drug, and they elected not to pursue it further. And certainly no one's going to recommend using a bispecific therapy or using combined biologics as a first-line agent for everyone. But it's good to know that this may be an option in very select patients. Summary: there's very little, if any, prospective treatment data on early onset psoriatic JAA. For late onset, modeling after the adults with psoriatic arthritis, we recommend domain-based approach. Pediatric studies are needed, pediatric indications are needed, and golimumab shows a pathway whereby this might be possible. And thank you for your time.
Thank you so much, Dr. Stahl. It's amazing to me when we sit and have discussions like this, how little we know and how much empirically is being done to try to care for our patients. So thank you very much with that, for all of your insights. With that, I will turn it over to Dr. Codoro and to the whole panel to discuss the case.
Okay, so I want to thank everybody for your outstanding talks, and we will now move into a moderated case discussion. So we'll start with the case I will introduce, and our panelists will share their expertise. The idea here is that this is a real life clinical situation. This patient, the first patient we will talk about, presents to the Rheumatology Dermatology clinic. And so let me set the stage and then we'll hear from our experts. This is the patient that I introduced in my talk. This is a 10-year-old boy. He has had psoriasis for 5 years. He's otherwise healthy. His psoriasis started with small plaques that progressed, and now he's red all over. His knees hurt on and off, a little worse in the morning recently. The patient's not sure if they swell, but overall, he's been really achy lately as his psoriasis has really progressed, become very red. He is not using any medications right now. He recently just had a course of phototherapy. He initially had something called Geckerman regimen, which got him a little better, but then he flared. He had narrowband UVB, which got him a little bit better, and he flared. And now he's looking the way he looks here. He has recently been very angry at home. He's had rage attacks. He's socially withdrawn. Socially, his parents are divorced. He has a strong family history of autoimmunity. His mom has vitiligo. His dad has psoriasis. And I just want to point out the green circle here. He was biopsied just to be 100% sure that this is the right diagnosis. And he does indeed have psoriasis. He presented, he had been out of school for the last 4 weeks. His mom was in the room in tears. His father's very frustrated, and they are asking for our help. So I will ask Dr. Peller if she would like to just comment on the skin exam and the clinical features of his morphology.
Sure. I mean, this is a boy who's clearly severely affected with areas that almost look erythrodermic in other areas. I'm very interested by the father with psoriasis, and I'd want to know a little bit more about that. I don't know who brings him in, if there's an opportunity to evaluate, but here's a boy who clearly has some involvement on the face that's somewhat patterned. He's got these clear areas that are erythrodermic and some skip areas. I'd sure want to know too if he has a CARD14 mutation and his father as well, given that kind of a family history. And that might direct how I might consider his therapy as well, given the pathway that we know is involved there. So a very severely involved boy who really is a candidate for systemic therapy. He's got areas of swelling as well. I mean, he's peeling, something we don't often see unless there's a lot of edema in the skin. And I don't think those are pustules. I think that you're just seeing some scaling coming off there, but severely affected and probably in a lot of discomfort. I wouldn't be surprised if he's in pain and certainly could be itchy here. And given the social situation, given what's happening to this poor boy from a psychological standpoint, and then to have to live with this chronically and be quite uncomfortable. So clearly someone who needs our help.
Absolutely. And I can fill in some of the details. So he did not have pustules, but he did have this crusting and peeling, which was cultured. It grew a little bit of staph epi, skin flora. So he did not have an active infection. And we assumed, like you did, that it was just oozing and weeping from how severe his erythroderma was. His father has plaque psoriasis that was onset in adulthood. They declined genetic testing. So we actually don't know if he has a CARD mutation, which is an important part of his management. Both parents brought him in, and it turns out his father is on adalimumab or Humira. And so they, the derm assessment, as you just mentioned, he had plaque psoriasis progressing to erythroderma, and he definitely needs a systemic agent. And there was the matter of the pain. He was kind of wanted to be in this flexed position. And so would our rheumatologist be willing to comment on this child and how we might approach looking at his joints and thinking about working him up to figure out if his pain is arthritis or not?
Sure. I mean, the first thing I would want to do is get just a little more history. I know you mentioned the pain in the morning, but asking some questions about whether he's particularly stiff Does he limp when he gets out of bed? And then does he loosen up somewhat as the morning goes on? And then I would want to certainly do a good physical exam. You know, as I'm looking at these pictures, I'm also wondering if it will be, you know, if this skin is warm just by virtue of the erythroderma, which could be confounding and make it more challenging to evaluate for warmth in his joints. Similarly, if there's a lot of edema in the skin, that can make a joint exam a little more challenging, or if the skin itself is just painful. But if, you know, if we are able, we may be able to elicit effusions in that big looking knee. If the exam really wasn't doable, options could include getting a bedside ultrasound if that was possible. And again, if it was tolerated due to the pain in his skin, or potentially an MRI.
Excellent. Dr. Stoll, anything to add?
Only thing I would add is that you can ask a question, if let's say he has subtle arthritis, is it necessarily going to change what you would do? And this speaks to what I was talking about earlier. I think we know which direction I'd want to treat him with based upon the severity of his skin disease. So for my thoughts, the main thing that if I found arthritis that would change would be, that means, as Dr. Lawson spoke to, he's going to need some uveitis screening, which you wouldn't necessarily do for psoriasis by itself.
So I can add some history then. So the patient, on eliciting more history per your request, the patient and his family report that he really never had morning stiffness. He never had any swelling. He's limping a little bit. He's hobbling around a little bit because these erosions and the skin oozing is a little uncomfortable. But they note that it only became uncomfortable when his skin turned red like this and started to swell. He did not have any on his joint exam. He's a little edematous in the skin, but it was thought by the rheumatologist that saw him that let's approach the skin and reconsider the joints. It was thought to be fairly low likelihood that this patient had psoriatic arthritis. And so we wanted to kind of get the erythroderma treated and have a second point of evaluation. So it was decided that we wouldn't get x-rays, we wouldn't get an MRI, we didn't have access to a bedside ultrasound. So we thought we would treat the skin a bit and wait. So let me show, okay, so your assessment is a little more information. Let's focus on the skin. So I wanted to ask, in this context, I have Dr. Amy Peller, but we can also ask Dr. Stoll and Dr. Lawson, would there be any particular workup that we might want to do, labs or other imaging if we're highly suspicious for comorbidities, or we've already heard about the workup for arthritis? Dr. Peller, would there be something more that you would want to do for labs? And rheumatology, would you want to order any labs?
I would say my biggest concern is this boy's mental health. I'm not worried about obesity. If my rheumatology colleagues didn't feel like there was something there, I wouldn't be going that route. And good history and physical examination is really what I'd feel comfortable with. But I'm very concerned about the mental health issues here. This boy's already in a situation where there is stress with the divorced parents, with a highly visible problem. He's just seems so miserable. And then already that he's having issues. So my focus would be on evaluating that and getting some help for him as quickly as possible so it can be appropriately assessed, and probably getting family counseling, not just some support for the boy.
Excellent.
Yeah, I agree that as far as labs go, my main driver would actually be just thinking about what we want as a baseline before we start him on systemic therapies, not so much for the purposes of diagnosing arthritis. So I would want to get a quantiferon to screen for tuberculosis and make sure that's negative. I would want to get a baseline CBC. I'd want to get baseline liver and renal function.
Okay. And that turns out that's exactly what we did. So this patient, it wasn't clear what the drivers were in total of his mental health condition at the time, whether it was situational or intrinsic and so forth. So we thought about that. We wanted to get some treatment going, some lab workup, get him on a systemic therapy, and continue to revisit these options in a multidisciplinary way. So at this point, how this story plays out is the patient, assessment is severe psoriasis, had planned for a TNF inhibitor, particularly adalimumab, given father's preference and being on the medication, and they have experience with it. The insurance denies it. So they say he's not tried any other therapy, so you have to do a step therapy. So we decided to plan methotrexate, which is an excellent drug, the most commonly used systemic therapy for psoriasis, probably worldwide. Plan to start it. So we put him on a triamcinolone 0.1% soak and seal regimen, ordered the baseline labs as you all suggested, including the Quant Gold, and started him on a test dose of methotrexate, which is a small dose with the idea being checking the bone marrow response to methotrexate in 6 days to just make sure there's not sort of an idiosyncratic bone marrow failure. And the test dose is really controversial and not everybody does it. But I wanted to hear from the panel about whether or not you do a test dose or if you just jump right into the methotrexate full dose.
Well, I jump in full dose. And
I do as well.
I've been doing that for 30 years here, and I have, and my entire group, there are 9 of us, and everyone does that, and at least maybe we've been lucky because idiosyncratic is pretty rare, but nevertheless, fortunately, we've not had that problem, and I often like to get things going pretty quickly. Now, you know, when you're talking about a small child, 5 milligrams, not such a small dose, but of course we want to be in the range of minimum of 0.3 milligram per kilogram per week in a starting dose, and kind of going up from there as needed. But I don't.
Okay. Let's show you what happened then. So this patient got put on soak and seal, a test dose of methotrexate, which probably did not contribute much to this, but this shows you what happened after 1 week of a mid-potency topical steroid after a bath. And he was probably 30 to 40% better, much more comfortable. You can see his physical, he's standing upright, the oozing and weeping is gone. And so here he is only 1 week after topical therapy. And I would love to hear so we escalated his methotrexate because his CBC was normal, but his LFT was a little bit elevated at baseline, which we thought was due to probably the degree of systemic inflammation, just a little bit of AST, ALT elevation. And we started him on folate to counteract the potential side effects of methotrexate. And we continued to work on his insurance appeal. So my question for the panel, let me see where we are. Yeah, okay. Here he comes back after 3 doses now, about a half a mg per kg. We escalated him up to 12.5 milligrams per week of methotrexate. He remains on soak and seal, and he is this much better. So do we continue the methotrexate, or do we go ahead and add the adalimumab if it gets approved?
Will it get approved if he's done so well on methotrexate? I mean, that's certainly one of the questions. I think it's this boy responded beautifully, and methotrexate is not a dangerous drug. Our rheumatology colleagues will certainly tell you about how much they use it. We use it much less. We go to biologic as a single agent so often in dermatology, and I think that's obviously something to discuss. But I think I would just make sure the parents were comfortable with this, but continue him on the methotrexate when someone's doing so beautifully. We don't have any guarantee that the biologic would work as well. And here we know that he's doing very well, and certainly keeping somebody on it as long as his laboratory tests are fine in continued follow-up is not dangerous as we know it.
And at this point, the rheumatologist saw him again and determined that he did not have any evidence of psoriatic arthritis, just on physical exam and questioning. His myalgias, what we thought were maybe arthralgias, had gone away. You can see he has no swelling here. So I already asked this question. There's no arthritis, so there's not a joint reason, but look at what we did. So the as we were appealing, and I did a peer-to-peer review saying this patient's very severe. We have him on methotrexate as was required. He is doing better, but why? But with a family history, with the severity of his disease, in shared decision-making with the family, decided that we wanted to move forward with the adalimumab. And I have on here why, and those are the reasons. So the family wanted to give him the biologic. And so we started the adalimumab because of his severe disease, his comorbidities, the mental health issues, and so forth. And the next question I have for our panel is, we continued him on low-dose methotrexate thinking the adalimumab should kick in, but should we keep it in order to reduce those anti-human antibodies? And are there data for this? Most of the data is from the rheumatology literature, and I'd like to hear from the rheumatologists what you think about this, keeping methotrexate on in this context.
So I do often keep with low dose methotrexate because it has been shown to decrease the likelihood of formation of anti-drug antibodies for patients on Humira, as long as it is well tolerated. Okay. Dr. Stoll, I don't know if that aligns with your practice as well.
It does, especially if they're using infliximab where the risk is a little bit higher, then they'll really try to talk them into taking methotrexate, even if it's not helping their disease. Now, in this case, it clearly is helping the disease. Probably, and I agree with adding adalimumab since it wasn't sufficient, but I would, unless there are some really intolerable side effects, I would keep them on this as well.
Okay.
And one of the things I do want to point out, though, is that to see this dramatic a response from methotrexate after such a short period is actually a little atypical. In my practice, it can often take a few months to get to a decent amount. So the fact that we saw partial improvement at such a quick period of time to me was actually very encouraging, which is why, even though I'm a big proponent of biologics, and I think overall they work faster and they work better than the methotrexate, regardless of any potential difference in safety, which there may not be. I still think that in this case, I was so impressed at how quickly it worked, which may well have been in part the parents really doing the soak-in treatment with the topical as well. That's why I said, I might wait a little bit longer. But I will say in my own practice, I really subscribe to the concept of shared decision-making. Clearly in this family, it sounds like the father did so well with the adalimumab that he wanted that success for his son, and the concept of its safety was something that played in here too, with personal experiences with that. So obviously we have to think about that as well. But methotrexate was pretty impressive in the face, at least, of topical steroid as well.
Yes.
Yeah, I agree. I would ask the question of whether this is actually topical steroid effect that we're really seeing here. I don't know how good they were with their regimen before, or what their regimen was, but I would also question how much this is actually the methotrexate given the dose he was on and the very short duration.
Right.
Although with the severity of his psoriasis, with the tremendous amount of erythroderma he had, we can't usually get that under control with topicals.
That's right. And this leads us to wonder, did he have a URI? Was it something about coming off of the phototherapy that then he went into such a severe flare? And this is not the typical situation that we often see. It's often a very straightforward decision, but this is why we're reviewing this. These more complex cases bring up a lot of issues. And also, just to point out for the participants, there's no one right answer here, right? You're not wrong to start the adalimumab, and you're not wrong to continue the methotrexate. In his case, and I think that he did have he started to plateau a little bit. He still had quite a bit of psoriasis, even though dramatic difference from the erythroderma, which also played into the decision. So over time, he continued to clear and clear and clear. And so how this case ended up evolving is we had continued to plan to continue adalimumab indefinitely. He was finally getting better, having a little bit more of a normal quality of life. He returned to school. He wasn't ashamed to wear shorts and t-shirts. We tapered the methotrexate down to 5 milligrams a week, really just to maintain maybe some anti-human antibody prevention. His baseline LFTs, I mentioned, had been elevated. They resolved with treatment. His subsequent labs to monitor the methotrexate remain normal. And as Dr. Paller suggested, we did refer him for therapy. We think he probably has intrinsic some depression and anxiety, and the anger and rage attacks were brought on by situational factors, being his psoriasis. So he ends up now, I just saw him actually at the end of 2020. He's 99% clear. He's got a little wee bit of psoriasis on his belly button. He remains on adalimumab, and actually, in fact, he stopped the methotrexate. He said, I stopped it. I didn't think it was doing anything, and he has remained clear. So this is a really nice outcome for him. He's not developed any joint symptoms, and the question about follow-up and long-term use of biologics is really important one to wrestle with. When might we stop it? When might we taper it?
Can I just ask a question too?
Yeah.
Because I think this is really important to point out. Even in our patients with mild disease, we're using a lot of these potent topical corticosteroids. My guess is that he's done so well, he hasn't had to put any on or wanted to put any on for a long time. And so I'm just wondering if you could comment on that, because that's what I see so often in my older children and teenagers who may initially not want to have the injections. They're always worried about that, but they are so happy with not having to put on topicals.
I agree. I don't think that kids not wanting to put topical therapies on is necessarily a reason to move to systemics, but once they have enough body surface area that it's not feasible and it's difficult and it's too much to rely on, once they get clear like this, they just absolutely do not want to use topicals. And a little bit of psoriasis is acceptable. And so there's that battle to play then with tapering, and if the psoriasis starts to come back, they don't want to use topicals, they want to stay on their biologics. So endpoint is definitely something to be discussed. So without further ado, I don't want to cut into the time that we have for our next case. So I appreciate that outstanding discussion, and we can answer questions from the audience in the chat, and shall do so while Dr. Stoll is teeing up the next case. Thank you.
Let me try again.
Thank you very much for the excellent first case, Kelly. The one thing too, and thank you, Dr. Lawson, for answering some of the questions in the chat. Please feel free to do that. If you do want to come on camera, there's a small enough group of individuals with us tonight, so please feel free to do that as well. And let's move into case number 2.
Okay, so this is a child who starts off in the rheumatology clinic, and then will be seen by dermatology. And this is actually an amalgam of multiple patients for educational purposes we combine in one case. So this is a 6-year-old female who's referred for pain in her left third finger ongoing for several months. She did not recall any trauma, and she was seen by her pediatrician who saw some swelling and was then referred to orthopedics. They got an x-ray of her hand, which the family was told was negative for fracture. There are no systemic symptoms, no prior medical illnesses. Family history is significant for chronic back pain in her dad, who has never seen a rheumatologist. So this is what she looked like. Her middle finger is swollen. If you look carefully, her second finger is a little bit swollen as well. And this is an illustration of dactylitis, a fusiform dactylitis that Dr. Lawson spoke to, where the entire finger is swollen. She also has some nail pitting. So Dr. Lawson answered this question with the differential diagnosis of dactylitis, trauma, sickle cell crisis, infections such as tuberculosis, psoriatic arthritis, and sarcoidosis. So we got some labs, CBC, metabolic panel, inflammatory markers were all normal. She is HLA-B27 positive, and we obtained TB testing, not so much because we're concerned about TB as a cause of the infection, as a cause of the swelling in this afebrile child with normal inflammatory markers, but because if we're going to put her on biologics, we're going to need to have a negative TB test. So we got an MRI, and this is what you can see. This is very similar to the MRI that Dr. Lawson showed earlier. You look at the joints, and the joints are not all that bad. This is, and again, this is a different patient, which is why a different finger and different hand is lighting up. around the MCP, maybe a little bit of fluid here, a PIP, maybe a little bit of fluid. What really stands out is very substantial inflammation. And I'm sorry, this is a T1 weighted post-contrast image. Very substantial inflammation along the bone, maybe some periostitis, tenosynovitis, and this is why clinically we're seeing dactylitis. So that confirmed the diagnosis. So we diagnosed her with psoriatic JIA based upon arthritis, nail pits, and dactylitis. And we started methotrexate, the standard dose, subcutaneously. And the patient was much improved at her follow-up visit. So we maintained her on methotrexate. However, sometime later, she develops a rash on her knees. So she comes in with a rash, and we say, what is this rash? Is this psoriasis? Is this eczema? Is it something else? So now I'm going to turn to the dermatologist and ask them, since I referred her to dermatology, I'll ask our dermatologist to walk us through this rash.
I'm happy to go if you want, Kelly.
Yeah, please do.
All right. Well, I think that this would be one that would be a little bit of a no-brainer. You've got very well demarcated plaque that is topped with that typical white color of scale. I think if you look in textbooks, you might see a lot more heaped up scale, but again, we talked about in children, oftentimes these plaques are thinner. We see that it's oozing a bit, and I think that maybe because this person may be scratching a bit, and that's giving excoriations, but it's a fairly typical psoriatic plaque, and I would not be thinking atopic dermatitis, even though it's itchy. As I said, itching is a sign, or a symptom rather, of psoriasis in many patients. Now, if this were a little more diffuse, I'd probably plunk it in the category of psoriasiform dermatitis, but the morphology is still that of psoriasis.
All right, thank you. So initially, she was treated with topical therapy. However, the rash progressed, and now she looks like this. So if you would talk to these rashes as well, if you would please. I know, and actually these are shown briefly earlier in the presentation.
Can you tell me what topical therapy she was placed on?
Some topical steroids, as a rheumatologist might not know what they're on. They'll just say they're taking a cream.
Okay. I asked that because, and as mentioned earlier, the response in psoriasis requires a higher potency topical corticosteroid and for a longer period of time. And I see people using creams when ointments should be used. So I would never think about starting psoriasis on something that's not at least a medium to potent steroid. And frankly, typically I will start with either a potent steroid or a super potent steroid, if possible, combined with a vitamin D3 analog if I'm treating anyone with more limited disease and I'm going topically. So I'm only raising that because, not that it wouldn't have been appropriate to move on, especially if there's more extensive involvement, but just because so often inadequate topical therapy is prescribed.
What about on the face? I was always taught that you don't want to use a lot of steroids in the face.
Well, one can jumpstart it, certainly for a few days to even a week on the face, but we do like to use a non-steroidal agent. And the favorite agent is something like tacrolimus 0.1% ointment, which actually it's generic now, and people there are ways to get it with coupons for a very low price right now. So that would be our treatment of choice. And I think very few on the face don't respond to that. Now, getting into the scalp is a little bit more difficult. But use of non-steroidals like the 0.1% tacrolimus can be very effective.
Okay. So this child was started on etanercept because she was already on methotrexate, and the rash started to improve on etanercept, but then she developed abdominal pain. So when someone has abdominal pain, they're on methotrexate, one of the first questions we have to ask is this an adverse event or just something unrelated? Could it be inflammatory bowel disease, irritable bowel syndrome, some other unrelated cause? And one of the clues for methotrexate adverse events is that this is really specific to the day or so after the injection. And so we lowered the methotrexate dose because we were getting that kind of history, and her repeat labs remained benign. We also obtained a fecal calprotectin level, which is 20, which is completely normal. Thinking ahead to which biologic might be used in the future, knowing that if she does have inflammatory bowel disease, then IL-17 inhibition is off the table. So although this is reassuring against IBD, she nevertheless still has active psoriasis while on methotrexate and etanercept, and her joint pain worsened on the lower methotrexate dose. Therefore, we switched her to adalimumab. While on adalimumab, she developed low back pain and stiffness. So we obtained an MRI of her sacroiliac joints. And this is what this looked like. This is your sacrum, the ilium. This is a fluid sensitive sequence, a stir sequence without contrast. And you can see here and here, we're seeing some increased fluid signal indicative of bone marrow edema. Now, also I'll point out a little bit over here, the margins, some rheumatologists or radiologists might look at this and say, this could be abnormal bone marrow signal as well. In a young child, it's pretty normal to have a little bit of bright signal on the margins. This is a normal developmental stage due to increased red marrow or hypercellular marrow, but this is not red marrow, this is active inflammation. So now we have a patient who has sacroiliitis. She incidentally is HLA-B27 positive, and she has psoriasis despite methotrexate and adalimumab. Although ustekinumab would treat her psoriasis, this may not help her SIJ disease. Fortunately, we obtained a fecal calprotectin level even before starting adalimumab, so we felt pretty good about putting her on IL-17 inhibition, ixekizumab. Now, if we tried to get that approved for JIA or ERA or psoriatic arthritis, it'd be bounced back to us with a denial. However, if we say she's got psoriasis, which she does, then we're going to get this approved because it's approved down to age 5. 6 months later, her skin and joints were in remission.
I have a question for you.
Sure.
So I think this is an interesting discussion point. So we in dermatology tend to give oral methotrexate. I find that our rheumatology colleagues tend to often, if not exclusively, give injected methotrexate. I'm wondering if you can comment on what you tend to do and the rationale. And I only say that because in dermatology, of course, part of our discussion in terms of decision-making with family is they're not so keen on giving the child a shot at home if they can give it orally. So my question, I'd love to learn a little bit more about the true difference, evidence-based, in terms of oral versus injected methotrexate.
So first of all, if I saw you're a patient with derma, where now her skin is red and inflamed, I would probably go with oral as well, if I were going to give methotrexate. But in general, we know the absorption is erratic when you give oral, especially at higher doses, whereas with sub-Q, the absorption will be full. There isn't, to my knowledge, a whole lot of comparative data. We know that there's certainly, you can start with oral and then get an improved response if you switch them to subcutaneous. If you present it to them as this is more effective, it's once weekly injection, it's not a particularly painful injection, most of the time, and the side effect profile is similar, most of the time they're on board with subcutaneous injections. And methotrexate is, as was mentioned, is a slow-acting medicine. So you give it oral, you wait 2-3 months, they don't have a great response, have a higher dose, and you switch them to sub-Q. By the time you've done all that, 6-9 months have passed, whereas you go straight to sub-Q, you know it's the right drug for them.
Okay, thank you.
I have a question for a rheumatologist about endpoint of biologics for psoriatic joint disease.
Yeah, that's a great question. Yeah, I know. And, you know, similarly, we wish we had better answers, better data to answer these questions. But the general recommendation, so there is data to show, and the way I usually explain it to my patients is that the longer you stay in remission on your drug, the more likely you are to stay in remission when you come off your drug. So that's why we don't just like stop things as soon as you're feeling better, because there will definitely be families who ask like, okay, we're better, can we stop now? So I usually aim for 12 months, but we'll sometimes stop at 6 months if the family is really itching to get off But usually, you know, if they're tolerating it well and everything's going fine, then I usually will aim for 12 months of remission on medications before I either stop or taper.
And do
So
you
I
ever
actually
just
have-
stop or tend to taper? Because we tend to taper in general when we're going off something, looking for evidence that something might flare. But of course, with psoriasis, it can take a little while before it flares. It's not quite as reactive as atopic dermatitis and use of biologics. So do you traditionally taper or do you stop and see what happens?
So I think practice is really variable. Similarly, arthritis will often stay in remission for a little while before it flares. Sometimes they'll flare immediately, but sometimes they won't. Generally speaking, if I have a patient who went into really quick remission, has done very well, I will stop. And if I have a patient who is very difficult to get into remission, then I will taper. But that's my practice.
Thank you.
So I have one general question, and then regarding the case, and then there's a couple of other questions that I have that have come in to us that I want to make sure we can try to address in the last few minutes together here. But the question relating to the case or just pediatric treatment in general, you know, with adult biologic use, we often, you know, we fight as the National Psoriasis Foundation to make sure people don't have to take holidays due to insurance or, you know, step therapy or changes in employment or whatever else, because what we see in adults is when an individual stops on a biologic class, oftentimes restarting, there's not the effectiveness. And we already talked about antibody formation and why that happens. Obviously, the immune system is still developing in a lot of the pediatric patients. And the data are still evolving for adults, right? So that's not always the case, which is really interesting. But do you have concern with tapering or stopping, particularly if a family is really like adamant, I'd like, you know, my child to be off of the therapy for now, and then possibly having to restart or retreat as adults?
I can certainly comment from the psoriasis perspective that I do have a concern about it, because we know that all of these drugs are immunogenic, and this gets into survival, you know, the so-called drug survival and how long they last in the body. And so there are, you know, that's why I was showing that diagram at the end of my talk, that we traditionally have thought about biologics as being start and continue. And in adult psoriasis, I think that's the paradigm. However, when you start a 6-year-old or a 9-year-old on a biologic, you can't imagine, you know, the next 60 years or whatever. You have to think about attempting to taper, whether it's reducing the frequency of the injections or reducing the dose. But then there is that concern, as we know with infliximab, however, that's a human mouse chimeric molecule. Patients get infusion reactions and may not have as good efficacy when they restart infliximab after a trial off. There's a meta-analysis of adult data showing that there is efficacy in regaining of control with all the classes of biologics other than infliximab, with intermittent use after a brief drug holiday for various reasons. So I'm not sure what Dr. Paller does, but I have not yet felt comfortable stopping patients and using intermittent therapy, because we just don't have that many tools in the toolbox. And I don't want to lose an entire potential drug class because of development of human anti-human antibodies. So, but it's also hard to justify keeping a patient on longer than they need. And I agree with Erica Lawson. I keep patients in remission at least 1 year and try for 2 before starting to taper. And that's all art of medicine, because there aren't any trials telling us what to do and how to stop. And I'll yield the floor to Drs. Paller and Stoll about their and Lawson about their thoughts about that.
Yeah, staying on psoriasis, I have to say, I don't have that many parents who say to me, I want to get them off of the drug. I think when we're treating these children who are so severely impacted, and the parents see the often dramatic change in not only their skin, but their whole psychological state, and they become happy kids, it's something where they're very hesitant to. And also, since we're treating a lot of the time in the teenage years where they're terrified to come off of it. They don't want to come off of it. And so far, it has seemed to be safe to stay on for a while. So I can't say that I very often have stopped it. I have certainly been able to come down to a little bit less there's some evidence that some of the newer medications may not have as much of an neutralizing antibody response as, for example, the TNF inhibitors. So that's also somewhat reassuring. And I think I am going to be a little bit more comfortable once we get more of these agents around, and we already are, because we'll have other choices. But I have to say, I haven't taken too many off.
So I get my patients are all over the map as far as some who, the moment you start the drug, they're asking when can they come off of it, versus others who remember how much pain, stiffness they were in before we started it, and they're in no hurry. I think for the ones who are, and this is more of a strategic than an evidence-based answer, but for the ones who are really adamant about stopping it, they're probably going to stop it one way or the other. So at least if I can work with them and say, okay, let's slow it, lower the dose a little bit, space out the interval, see how you do for a few months, and then maybe stop it, versus they're going to stop it, not come back, and really then suffer for it.
Dr. Lawson, any further comment?
I'll just say this is definitely a place for shared decision making with families.
Yes.
You know, kind of to Dr. Stoll's point, while I was saying that, generally I will start talking about coming off when we are approaching 1 year in remission, especially for patients who easily went into remission. That being said, for families who want to stay on, I don't ever force them off. So, if they feel like their quality of life is better with the injections than it was without them, then we stay on.
Yes.
Okay, now we've reached the rapid fire round because we're a couple of minutes over, but I want to get these last two questions in. One is targeted more to psoriasis and one is more to JIA. So from a psoriasis standpoint, do you see any challenges or difficulties or increased prevalence during development? So during breast development, during genital development, where there's an increase of guttate or plaque psoriasis in teens as they're basically entering puberty?
It's so hard to know because we already know that that's the age where we're seeing it going up epidemiologically, and I don't know that anyone's correlate that with Tanner staging and exactly where they are. So I don't know the answer to that, but it's such a linear curve going up, starting from the young children and through even before puberty, that I don't know that it has anything to do with puberty, but I don't have any evidence basis for that.
Yeah. What we do know is that there's a big peak right around age 10. In our data, we just looked at about 800 patients, and there is a huge peak around age 10 of at least presentation to dermatology and often onset of symptoms, and then another one in adulthood. But I agree with Dr. Paller, we don't know for sure, but I do know that of all the adolescents we see, we don't see major, we don't have enough evidence to counsel pre-adolescents, like, boy, when you hit puberty, we are in big trouble. We need to brace ourselves. We know this is going to get more severe, or fortunately, when you hit puberty, this is going to get better. It often is, in many ways, maybe a neutral event. But I agree. We just don't know, and it's compelling to think that hormones play a role, but we haven't seen that to date. But it hasn't been looked at in a structured way. So that gives us another project to do.
Yeah, and I think if I were looking at that too, I would certainly want to also take into account the body mass index, because that changes too with puberty and may tilt the scale.
For sure, that's a really good point. And then related to JIA, are there any data or any thoughts on athletics? So we talked about the Kogner effect for psoriasis and injury and that type of thing. We have a number of parents that have come and said, my child started tackle football and this happened, or, my child was, injured at soccer and then they ended up having some presentation of, joint symptoms. And, frankly, from a National Psoriasis standpoint, a National Psoriasis Foundation standpoint, we don't have the correlative data. Having two teenage daughters myself and having one just go through an ACL repair, injuries are common for teenagers, right? So how does that play into, from a joint standpoint, but really even just potential flare?
So that is
Dr. Stoller, Dr. Lawson?
That's an excellent question. In the adult literature, there's some data showing that post-traumatic psoriatic arthritis flares are more common than post-traumatic rheumatoid arthritis flares. And it's been called, I think it was Dennis McGonigal who called it the internal cabinet phenomenon, where the same sort of biomechanical forces, trauma can cause a flare of the joint disease. So when we see that, and there's an animal model of spondyloarthritis where the disease goes away or just on a curve, they're suspended so they don't bear any weight on their hind paws. So it is something that we struggle with. On the other hand, no one wants to tell a kid, just crawl into bed and don't be active. I try to discourage football because there is so much trauma involved, especially my kids with psoriatic or spondyloarthritis. When you're in Alabama, sometimes that message will not be taken very well. If it is someone who can play multiple sports, I'd much rather them play tennis, baseball, soccer than football. So I do want them to be active. I do encourage athletics, but certainly for the ones where there's going to be a lot of injury, a lot of trauma, I would not encourage football or try to discourage it.
Dr. Lawson, any further comment?
Yeah, I mean, I agree with all of that. Just, I think looking back, it's also very common to have families come in with a new swollen joint and be like, well, I think like 2 months ago, they like tripped on the playground. And then like maybe 2 days later, we started noticing something. So people do, it's a very human tendency. We all want a reason for things. And so there's this really natural tendency to kind of correlate in your mind, like, and try to identify a cause. And who knows, sometimes maybe those really are causative and sometimes it becomes clear that they're probably not. So often I think it's really hard to say, but I definitely agree that being active is so important for our patients with arthritis. Every single visit, I'm asking my patients, like, what are you doing to move your body? And obviously you want to do the things that are the least painful. Swimming is great. But honestly, I tell my patients, I don't care what you do what you like, do what is fun for you, but it's so important to keep moving because that's how you keep that strength and range of motion.
Well, thank you very much. I want to be mindful of time. I also want to just say a final thank you to Pac-Man, an organization that has partnered with us, really has been, a great partner, collaborating with us on coming up with some new ideas for our collaborative efforts. If you're not familiar with Pac-Man, I would encourage you to check out their website as well. They have their annual meeting coming up soon. Just a fantastic group. I'm very fortunate to work with a number of their board. And I'd really, like to sincerely thank them. And then finally, I'd really like to thank our faculty panel. I mean, this has been exceptional. It's so wonderful how everyone's presentations aligned and the information that we provided to the community. And with that, I'll turn it back to Dr. Codoro if she has any final comments.
I just want to echo that. I thank everybody, all the participants. Thank you, Stacy and Shiva, for organizing, and thank you to Drs. Lawson, Stoll, and Paller for your exceptional talks, your tireless dedication to the research and advancing the knowledge, and most particularly to the patients who all of the work benefits. And I want to thank the National Psoriasis Foundation. For generations, it's been there to support research, to support clinical knowledge, and to support patients. And I feel really honored and privileged to be a part of it, walking in the large footsteps of Dr. Paller, who has been working with the organization for much longer than me. Dr. Paller has been a role model to me in all things psoriasis, and it's just a great team to get to work with. And I want to thank whether you're physicians, allied health, family members of patients. I'm not sure who all of you are on the event tonight, but we're very grateful for your participation. And please reach out if there's additional questions. So Stacy, if participants have additional questions, I'd be happy to help in any way I can with that. So I just want to thank the whole group and thank Ekamini for helping us to organize this, though she couldn't participate.
Thank you.
Have a wonderful evening, everyone.
Thank you so much. Take care.
Thanks so much. Bye-bye.